Now, testing itself can fail. Every test involves a compromise. You have to choose, do I want to find every possible case, or do I only want to find the definite cases? And at the beginning of an epidemic, when cases are growing, overdiagnosing a few people is acceptable. But at peak deaths, you have to change strategy. You change strategy. Instead of focusing on the individual, you look at the population. Instead of trying to diagnose every possible case, you want to find the definite cases, and you have to change your laboratory strategy. So you may have heard people talk about restaurants and say that there are 3 things restaurants can do, but they can only do 2 of them well. You can have fast food, cheap food, or high-quality food. Well, it's the same with laboratories, but the 3 things are high volume of tests, high speed of tests, or quality test results. And you choose 2. We chose volume and speed. And actually, those are good ones to choose at the beginning of an epidemic, but we haven't changed our strategy, and we have compromised throughout on quality, which has resulted in unreliable test results. Somebody who's infected will release up to 100,000 virus particles every minute into the air. They're about the size, the aerosols are about the size of smoke particles. And waving a test swab through that air could be enough to have a positive test result. In fact, in a 5 microliter sample that gets tested from a patient, you need 5,000 particles of virus to represent a patient who's capable of infecting another patient. PCR testing has been set up to detect 4 virus particles. So just to make that clear, you will be called positive when you have got 1,000 times fewer particles in that sample than is needed to be an infectious patient. So the consequence of that is that low levels of bystander virus and immune people will both be called positive tests results and then cases when they have no evidence that they are a risk to others.